What I want to talk about here is the open approach to thoracoabdominal aneurysm in this environment of almost all endovascular work. There's a few disclosures. This is the problem, as you've already seen in a number of other presenters, the aneurysm of the thoracoabdominal aorta. And it is the primary objective to prevent these things from rupturing and having these patients die secondary to rupture and having an early death, losing their lives. I do feel like somewhat of a dinosaur talking about open surgery in this endovascular, but we'll give it a shot. This is the kind of thing that we see, these aneurysms of the thoracoabdominal aorta, and the goal is to have a repair with an intact spinal cord, visceral vessels, and lower extremities. This is just another example of what we see in postoperative repair. The natural history of thoracoabdominal aneurysms is very poor. This is from a report by Stanley Crawford in the mid-1980s, and just shows you that the mortality rate from these aneurysms after we were seen was most of them were dead within a couple of years, and most of those who died actually died from their aneurysm rupture. It's really not quite known what exactly the incidence is, but there's probably around 3 to 5 cases per 100,000 per year. Most of the guidelines recommend that for dissection and aneurysms with a genetic origin, somewhere around 5.5 centimeters, and for the others around 6 centimeters, and for rapid expansion, and certainly for any patient who is symptomatic. Operation is complex and involves protection of the spinal cord, kidneys, and visceral organs, as well as the reconstruction of the aorta. Etheridge from Los Angeles with a homograft is generally credited with repair of the first thoracoabdominal aortic aneurysm successfully, and it was a single case report. Others that have been interested and have done a lot of work, of course, have been Dr. DeBakey, initially with homografts and then later with Dacron grafts, but it was really Stanley Crawford who gave us sort of the modern approach to open repair of thoracoabdominal aneurysms. And he also gave us the classification, the extent 1, 2, 3, and 4, with the extent 2s being the most extensive from the left subclavian to the bifurcation. He operated upon 1,500 thoracoabdominal aneurysms with a mortality rate of 8% and a paraplegia paraparesis rate of around 16%. The extent 2 thoracoabdominal aneurysms, in his experience, carried a paraplegia and or paraparesis rate of almost 1/3 of the cases he operated upon. And he did show us, as we found since, that risks not only of paraplegia but of other things varies with the extent of the aorta which is covered and repaired. Believe it or not, in my work with Stanley Crawford early on, we didn't use heparin on these cases. We certainly have since then, and we've moved from a clamp and sew technique to a variety of adjuvants which help us, including CSF drainage and renal perfusion. And then in many cases, we've gone from an island repair to the use of multiple branches for the visceral and renal arteries. This just shows you in all extents, but we have randomized trials to show us for renal perfusion with cold is protective, and for the extent 1s and the extent 2s, CSF drainage, we've got randomized trials, and then for left heart bypass, we just have a lot of data. In my own experience over the years, we haven't always used every single one of these adjuvants, partly because we were in some prospective and randomized trials, so that we purposely didn't do that. But in the latter years, we've certainly been liberal about using all of these adjuvants. It's a big operation carried out through a thoracoabdominal exposure, which includes a double lumen endobronchial tube. We use the 6th intercostal space. We very rarely will resect a rib. CSF drainage for most of our aneurysms, except some of the very isolated extent 4s, is routine in our institution. And it's clear that it does have some risk, but when it's used frequently, the risks are fairly low. We've carried out some prospective randomized trials showing that in these longer aneurysms, particularly the extent 1s and the extent 2s, and here this is from a publication from quite a while ago, where we showed with statistical significance that when we use CSF drainage, the incidence of spinal cord problems